Well, hello, everyone, and thank you for joining our panel today centered around data as a competitive advantage to drive a personalized consumer journey and digital transformation. My name is Dr. Anil Jain. I'm the Chief Innovation Officer here at Innovacer and your moderator for today's session. If you go to the next slide, please. I am joined today by a panel of subject matter experts and colleagues from both Upstream and Innovacer. Upstream is one of the fastest growing primary healthcare solution providers in the US who work in partnership with healthcare practices and clinics offering a comprehensive risk-free solution for physicians that finances, delivers, and sustains better outcomes for everyone. Now, Innovacer is a healthcare cloud company committed to accelerating innovation by unifying patient data across systems and settings to empower healthcare organizations to rapidly develop scalable, modern applications that improve clinical, operational, and financial outcomes. With that, what I'd like to have each of our panelists do is introduce themselves briefly, and then we'll get started. Why don't we start with Lucas?
Hello, everyone. Thanks for joining today. My name is Lucas Sam. I'm the Chief Information Officer at Upstream. I've actually been in the technology industry for around 23, 24 years across a number of different industries, and have been with Upstream as the CIO since last May.
Thank you, Lucas. John?
Hey, good afternoon. My name is John Supra, and I recently joined Upstream as the Chief Data and Analytics Officer. And I've spent time both on the provider side with a focus on value-based care and population health and the associated data and analytics required to be successful. I spent time with state Medicaid and looked at population health, claims and eligibility operations, as well as a background in technology and technology accelerated innovation.
Great, thank you, John. Rachel?
Hi, everyone. Rachel Neely. I am in the growth strategy sector here at Innovacer, and my sweet spot is really within the consumer and patient relationship management vertical. So today's conversation is one that's very passionate to me, and it's really, again, about connecting that one-to-one health journey, really focused on using data to be able to guide a better experience than what we see today. So happy to be here.
Awesome. Hello, everybody. My name is Chris.
Rachel. Chris?
Sorry,
go ahead, Chris.
I'm a principal architect here at Innovace. I really focus on our data platform, how to pull together all these different sources of care and really help customers understand how it fits into their environment. A very deep background in interoperability. I spent 15 years at McKesson Change Healthcare, Relay Health, focused on health information exchange, opening up different EMRs, plus a year at R1 in the revenue cycle. So nice to be here today. Thanks.
Thank you, Chris. And Neela?
Hi, everybody. I'm Neela. I represent the product management side. And prior to Innovacer, I have my background in both management consulting as well as an engineer. So I really kind of bring both those aspects. And I'm very happy to be here and share the product lens into a lot of what we'll be discussing.
Thank you, Neela. And I just we'll put a full disclosure. That will be one of many technical snafus that I will create. I am actually at the airport coming back from Vive, which we had a fantastic conference. So with that, let's go into the agenda and sort of go over what we'll be discussing. So I think this will not be a surprise to any of the panelists who will sort of share their perspectives on it, but there's a massive rise in consumerism happening in healthcare. We've all experienced it either as healthcare professionals or as patients. And we absolutely see, and I think our panelists will share with us the learnings they've had around the need for high quality integrated data. And then how do we bring all that data together to create a one-to-one healthcare journey? And our hope is that if we have time, we'll take some questions from you all, and hopefully the material we'll cover will also generate some interesting new thoughts that you may not have had earlier. So keep the questions coming on the chat if you like, but we'll have hopefully some time at the end to take your questions verbally as well. So let's move on to the next slide. So what I'm going to briefly do is just give you a sense of where we see the state from our point of view of the rise of consumerism in healthcare. And then once we set the stage for this, I'd like to get all the panelists to give us their perspective. But we know that this rise in consumerism is happening at a pretty accelerated rate. And much of it could actually have been accelerated by the pandemic. But we know that the experiences we have throughout our rest of our consumer journey, whether it's in retail, travel, like the journey I just had in booking all my travel for this conference. We don't have the same experience when it comes to healthcare. And I'm not going to go through all the numbers, but none of this should surprise anyone who's listening, as again, we've all experienced it. But the one that I found striking, and I'm a reformed primary care doctor, if you will, or a recovering primary doctor, but actually a retired one, but that most of the patients who have a better communication with their provider when it comes to having it be personalized, most of them would come back and visit the same provider. And as we think about loyalty and patient keepage and things of that sort, this becomes incredibly important. And the themes that drive it, again, no surprise to any of you, would be that it needs to be individualized or personalized. It needs to be accessible. There needs to be a reason why providers and patients will create those communication channels. And it needs to be as innovative as what we experience in the rest of our consumer journeys. If you move on to the next slide. Now, when you start thinking about the growth of highly deductible health plans and where the first dollar, or maybe even the second dollar, is something that the patient consumer starts to control, it starts to change some of the equations. And as our upstream colleagues will probably share, things are changing rapidly, whether it's in specialty care moving to primary care, or primary care moving out of the four walls into alternate settings, or even delivering higher acuity of care in the home. We have to start thinking about the growth and the trends that are happening and what it means for the patient journey. And going back to the concept of keepage, we know that hospitals and health systems lose quite a bit of money when they don't have a good control over that aspect of it. And of course, in healthcare, we can't ignore the fact that there are real regulatory concerns and challenges, but then there are also perceived ones, and maybe we'll have time to get into some of those that create a unique challenge in trying to create stickiness and relationships with patients. And as we mentioned earlier, patients do have more control over how they spend healthcare dollars than they've ever had before. I'm sure we'll get into some of that in terms of whether it's moving fast enough or if it's still going slowly. But there is a massive amount of transformation happening. And that's an opportunity for all of us to think through what is the role of data and information in that transformation. So let's take a pause here, and maybe we'll have our panelists take a stab at some of these issues. One of the core themes that are driving consumerism today is that there's been significant progress made in healthcare. The healthcare vertical is nothing like what it was when I started practicing 27 years ago now. And in terms of the way that we've engaged, where do you believe the biggest advancements have been over the last 2 years? And why do you believe those are the advancements that we've seen as opposed to other areas? And Rachel, maybe you can get your thoughts first.
Sure. Yeah. I mean, the first thing that comes to mind, and perhaps it's a bit obvious, but I think it's expanded access out of necessity. So we're still here, unfortunately, in now year 2, which I think officially this week, year 2 of the pandemic. So from the lens that I sit, I think, there's been obviously limited access for many specialty care things. It's not the path I'm looking to go down right now. It's really expanding that access via telehealth, and honestly through urgent, immediate, and retail healthcare clinics, because of needing to get in based on what the pandemic has done to us. So I think it bleeds into some of the legislative changes too, right? Telehealth as an industry, we just weren't there yet 2 years ago. We had more of the mature healthcare systems that were looking to expand and to break down some of those regulations. And here comes COVID, and now it's a demand, right? But I think the biggest thing, not only did it change in the last 2 years, I don't personally see it going back, right? And I think about this from the lens of consumerism. Neil and I were talking this morning, as having, young children, you need that access regardless of pandemic or not to be able to have that quick access virtual care. So despite the negative consequences we've had because of COVID, I'm really excited to kind of hang the hat on the leaps and bounds that we have made through some of the access expansion.
That's fantastic, Rachel. And John, where do you think that the traditional healthcare verticals, and certainly your group, is supporting some of the transformation that needs to happen in these healthcare systems? Where do you feel like they're really failing to keep up with the consumer expectations? despite all the things
Thank
that
you.
Rachel has mentioned.
Yeah, great. Thank you. And I think both in how you kicked off those expectations, and as Rachel talked about, much of that acceleration that we saw within COVID relative to what's possible in telehealth, much creativity that provider communities quickly pivoted on, and a lot of the regulation that was being argued about, we can't do this, we shouldn't do this, this will harm patients. Well, it sort of melted away. And those are some of the realities that the community needed to respond to. So very much agree with Rachel and your lead-off comments that what healthcare delivered during the pandemic looked like what it was preparing for, looked like what is technically possible, and absolutely started to meet the needs of consumers in the ways that they experience in many other virtual interactions of purchasing, as you said, your travel, hotel bookings, or otherwise. So I think you've got this mix of policy and reimbursement, comfort for the status quo, and what's possible technology-wise. And what we see is this notion that the electronic health record, this area where do we keep our patient records? Well, they all came out of the notion of accurately billing for services. They didn't come out of the notion of customer relationship management. And there's been a lot said about what does that look like when we bring those two fields together, or technologies or mindsets, which I probably can prefer, we bring them together to change the way we deliver care. And what I think is the pandemic forced us to say, yes, we can do it. We've got a lot of work still around it. We've got a lot of history, but we've got to be able to ask the question of what is possible, why is it better, and the comments around access to care. Keeping young families out of emergency rooms is absolutely an important access to care question. What can we deliver safely? What can we do with the systems we have? And healthcare has absolutely lagged other industries in thinking about the experience first. I think everyone both on the panel and I expect joining us today have sat in hospital waiting rooms and emergency departments in their practice, and they've said, why am I waiting here? What does this look like? Technology, and there are some healthcare providers that have gone to, let me tell you if we're going to be delayed and send you a text message. Let me tell you what today's schedule looks like. And that adoption has fueled a better consumer experience, but I'd also challenge the industry to say, well, we've done better with scheduling and schedule management. We're delivering some telehealth services, but it's on us to think about how could we deliver care very differently as well. How can we meet the needs and some of the work that the upstream team is doing, particularly in senior primary care, is what other services beyond coming to the office can be provided? How can pharmacists be connected to the care team? How can social workers be connected? And when we do this work, we know that we can deliver a better patient experience, more communication with physicians and the clinical team, and better use of technology to make other things possible is where we have to continue to move within healthcare, I think, to respond to the financial challenges, the consumerism or experience challenges, as well as continue to push regulatory and policy changes that align to delivering that care. And I have 2 teenage daughters, and I think about their comfort in talking to people like Alexa and Siri and engaging with them. And how does it show up for healthcare? And we've taken some steps, but we've got a journey ahead of us.
That's really interesting, John.
Yeah.
I'm sorry, go ahead.
A personalized journey is the next opportunity. I'd say that, to your point, John, I think patient safety drove sort of raising the bar, if you will, around remote registration, around remote check-in, telehealth, of course. Suddenly it's a totally different experience, and the expectations across the board are at a different level of experience. And taking it to the next level is then really personalizing that. And the opportunity from a data perspective is there. You know, this is healthcare, so we know about our customers in healthcare at a level that no other industry does inherently. And the question is, how do we leverage that and other sources of data, from my perspective, and really drive a unique personalized experience above now a new baseline that the pandemic has really given us around efficiency in the front door.
Yeah.
Yeah, I think
it's really interesting. Could I
go ahead, Neela? Yeah.
Oh no,
no, I was just going to ask Neela a question.
I'm so sorry. I think the three of us are kind of talking over
Neela,
each
please
other.
go ahead.
Yeah, no,
Please go ahead.
the point that I was going to add is, of course, we've talked about, the importance from the patient perspective, but John actually mentioned something so key, which is how do we make that same data be available to different stakeholders of care? Because we have not traditionally managed to do that very well. And that is another impact of having really siloed data, because how can I make sure that the data is secure, is protected, can actually transcend different systems and be available to that particular stakeholder in the shape and form they need? And that's actually a really big challenge, I think, that we yet have to solve. Even now, when I call into my health system, I typically go through many rounds of being put on hold, transferred, and having to repeat my information. And that's a really key piece that you mentioned, John.
Yeah, I appreciate it. And responding to that and tying it to something that Chris was saying as well. Absolutely, in healthcare, how do we get comfortable with sharing that key piece of data? And I think also thinking about sites or places of care well beyond the traditional locations of a hospital, a clinic, an office. What can happen with this broader construct of a care team so you could be an employer's site of care? So the time to move between sites of care in a community center. We know that through the pandemic, the needs of our nursing home facilities, some of our community centers where seniors gathered, how do we bring care into different settings? And again, we believe that the care is still delivered by an expert care team, but it can be done in a lot of different places. And that use of data, the transfer of data, as you said, Neela, as well as a broader thinking about what sites of care. We saw what is a site of care, and I think I recently looked at or saw an article where the Cleveland Clinic is partnering with Cleveland Hopkins Airport to open a site of care within the hospital or within the airport. That's a great look at a different view on how, where, and why we provide care. And for a frequent traveler to stop in for a regular quick checkup, what does that look like? It's where the care is needed. And it's way more convenient. So that's some shift in thinking, where, as you said, sharing of data, the data sources, the exchange, in ways that healthcare, I think, is just expanding its thinking.
It's a great point. I want to make sure before we move forward, I've heard us talk about CRM, customer relationship management. And again, as a clinician, I really am struggling to make sure that we don't think of the CRM that we experience in other industries somehow, coming to healthcare and having it work out. So can someone explain to me how you all see the difference between PRM and CRM in terms of patient relationship management, and why we can't just take all those wonderful CRM tools that are out there and simply just pivot them and put them in front of patients and caregivers? Maybe any of you. Yeah, sure.
Yeah,
Rachel,
I mean, I'm happy to take the first stab, just knowing, my background does come from traditional healthcare CRM space, and it's good and it's great. But where traditional healthcare CRM stops is where really the patient experience begins, right? CRM traditionally has been focused on the upfront psychographic and the preclinical consumer behavior. What are the click paths that were taken? What are the things that were interacted with to draw that person into the healthcare system? And I still think that information is critically important, but where the gap has traditionally landed is after that appointment request has been made, what then? That's really when a person becomes a patient, right? That's the most critical area that still needs to be strengthened, again, by data connectivity to be able to really bridge that experience. One of the things that I've touted a lot, and I'll repeat again, is you are a patient for just a percentage of that entire journey. You may be a consumer for the entire one, but we as health system, verticals, providers, whatever space we all may be in, we need to stop breaking it down, in my opinion, between consumer and patient. Let's just call the entire journey the patient right? That's the goal, is to get folks into the system and to be able to connect with them, not only in their moment of clinical care, but outside, before and after that moment of clinical care as well. So I think the nomenclature is aged. I think we need to stop just leaning on the consumerism fact, to your point. We really need to focus on expanding it to be about patient relationship management. We are in healthcare. People at some point will become a patient, right?
Yeah.
So.
I agree with Rachel. Go ahead.
Oh, sorry, John, please go ahead.
Oh, I very much agree with Rachel. And I think we are creating a new space. You know, I had said earlier, EHRs really were built up from the billing mindset.
Yes.
CRMs, as Rachel said, have really been built up for the, I'll call it sales and marketing, the connection prior to, in healthcare terms, being a patient. There's a new space that connects the two of these. And I think to what we were talking about, it extends well beyond what we think is traditional patient care. But what am I doing? You know, I'll go back to an employer work site. What am I doing at my employer's site to think about the health and well-being of the team members? And where does that show up? What does it mean to have a senior community center that seniors are gathering at, where health and well-being is part of that experience? So we've got to find a way to bring it together. I think, to the question, the challenge with traditional CRM, if you think of it both in mindset and technology, it doesn't have the robustness of a clinical record that may be really important to somebody. But yet our electronic health records don't have the data breadth to capture things that happen outside. And in general, they're really focused on capturing those things that are billable. So we got to break that down. And I think we need to see either a new class or some deeper thinking about what interoperability truly means, beyond just sending claims and sending the clinical data, but being a rich experience world. So, and we may get to that later. So to add on to that, Rachel.
Yeah.
This is great. So let's see what our audience thinks. So if we move to the next slide. What are the biggest barriers to accomplishing your strategic priorities related to data analytics over the next 12 months? And you heard a few themes from our guests here. And so we're going to throw on a poll question, and we'll discuss it on the other end of it. We'll give you guys a few minutes to answer your question. Well, I'm going to make the assumption that everyone that wanted to answer the question has done so. So maybe we can have our team present the results, and I would love to get the reaction from our panelists. Well, folks. I mean, wow. So, any surprises? What are you guys seeing on this that's surprising you? Let's maybe start with Lucas.
Yeah. I would say that. Yeah, with those top two, not surprised at all. I mean, that is a continuing, ongoing challenge. Seeing that there's, the lack of funding, being up there, not too far behind. I mean, that's because it's such a critical need. I mean, organizations have to prioritize that from a funding point of view. But yeah, seeing those top two, I mean, those are, we see that day in and day out. So yeah, definitely agree with those first two results.
Any other thoughts? Any surprises? Anything that anyone else wants to comment on before we move forward?
Yeah, probably a lot of
I want to chime in
there as well. It looks like some folks probably filled out because they all are, I think, critical ultimately to drive initiatives like we're describing today. So, yeah.
I'd like to offer two perspectives, particularly on things that I think are faced in healthcare more than other industries. One being, when we talk about integration and interoperability, healthcare is still primarily after the fact, send me a file to integrate, I will integrate it. And again, in technical terms, an ETL sort of world. There's been improvement, there's been automation. It is not a world that is service-based like many other industries. So I think a lot of those challenges, not only are they real and need to be addressed, but we've got some fundamentals on what is broadly call it the architecture that needs to underlie healthcare from a service world. And I think on the funding challenges, I think one of the double-edged sword, particularly in data and analytics in healthcare, is everybody knows there's lots of data and they want an analytic or a report today to satisfy a narrow use case. I think a lot of people working in this space have been able to respond and, well, I've got that report. But the way we created a report is not scalable, it's not service-based, it's not repeatable, and then they want the next one and the more sophisticated one. And we're caught in this balance of showing today's value for the dollar and being able to put a different foundational architecture in place that I think the technology side of the world understands will be faster long-term, but it is going to take time in this industry. So those are some underlying mindsets that I always want to drive people back to think about how they impact even where we are today and what choices we may make or challenges we face as an industry.
Great point. Great point. Well, why don't we move on? We heard a couple things about data, so let's talk a little bit more about that. I think we've all sort of heard from our panelists about the need for high quality and integrated data. Interoperability as the fact that much work has been done in the industry, it's still somewhat elusive from a semantic, meaningful way. And we know that we do a lot in healthcare that is considered to be unnecessary, whether it's medical waste, fraud, or abuse. And if we could just simply figure out what that third that we spend money on that we shouldn't, or that quarter of the money we spend that we shouldn't, that would be amazing. But for that, we need really high quality data. We also have challenges where, at least in the US, we cannot legally have a common unique patient identifier. It's forbidden by Congress. So there's a lot of issues around patient identity. I know there's work being done by consortia all over the place in terms of positive identification of individuals, and maybe someday Upstream and Innovacer and others, you all on the webinar will be able to take advantage of it. But right now, it's sort of like everyone's sort of doing their own thing. We also know, and much of us cannot argue with the fact that if we had a 360-degree view of the patient, that we'd be making much better decisions from everything from clinical care all the way to care management and care coordination. And finally, perhaps as a result of the fact that there's no common identifier, but oftentimes health systems in particular have built up their health IT portfolios through various products and different systems that may not necessarily talk to each other. So those siloed data that may not be integrated or even linked can create some inefficiency, and certainly can create some two sources of truth when we all know that a single source of truth is probably much more relevant. If you move on to the next slide. So in this need for high quality and integrated data, we need to really understand how the sourcing of that data happens. Can we streamline the process of getting the data use down and the guardrails that one might need to have? An area that is near and dear to Innovacer is around how do we clean that data up and make it much more usable and much more consistent across the board. And they say in our field, if you've seen one EMR, you've seen one EMR. It's just every single implementation, whether it's the same vendor or not, is going to look a little different. And recent studies show that even within the same organization who has the same electronic health record across two different departments, there's very little consistency from an interoperability point of view. And then scaling the work we do around data. I know that the panel will probably have some thoughts on that. But we also know that half the folks, the executives, will say that data integration and interoperability are significant barriers to achieving their goals, but not all of them have a consistent roadmap on how to get there. And one of the sobering statistics that I saw on this page that's here is that only 20% of organizations fully trust their data. That is incredible. And I would love to get the panelists' perspectives on this. And Chris, you brought data in the last topic that we were discussing. Maybe you can start by giving us your 2 cents. If you think about the data sourcing itself and the different types of data that one might want to start with and go through. What's your sense, your experience, what data is typically available and what is typically lacking, and what the challenges are in getting access and getting that kind of data?
Yeah.
Can you give us a sense of that?
Sure. Awesome, Dr. Jain. Yeah. So I think from the perspective of like the different sources of data, John brought up the, build out that we've done on the EMR side, the billing systems inherently, and the claims side. There's so much insight that's been digitized right now around the consumer and the customer of healthcare providers that's already been digitized across these different EMR systems and these claim systems. But even within the four walls, there's so much complexity of getting a handle on that data and so many different silos that have been created. You got your pharmacy data, your lab data, your claims information, your EMR, and then you've got your network, patients seeing different care providers outside of the four walls. So you've got, that distributed care team, all with different parts of the health record, out there as well. That's from a sort of a clinical perspective. And then you expand it into different areas. This is like an exploding problem in the sense that the patient is creating their own information out there, whether it's home devices, whether it's this willingness that patients are to really truly share their healthcare information with their providers, fill out surveys, the sort of, patient created information that can be part of this overall data equation, and then you look at more traditional CRM inputs, whether it's the Experian sort of consumer data, discover more about the patients, what their magazine subscriptions are and whatnot. Not that anyone does that anymore, but, or if you, look at other sort of, like the engagement that patients have around the web and the internet and harness that potentially in combination with the sources of information, expanding that out again to patients that aren't even within your network as well, and how you might, engage with potential net new consumers and customers of the organization. And then the last, I think, element from a data perspective, you've also got sort of regional, you've got social determinants. You can infer a lot from where a patient lives, and how you can really bring that into the equation as well and equate that with the, patient entered information potentially as well. So sort of the landscape of all the data out there and the complexity when you've got transactional systems and all these different sources with different cadence of sharing it, pulling that together to be able to activate that. We call it normalization curation, call it aggregation as well. As Dr. Jain pointed out, you've got these no consistent way of identifying the same patient across these different sources and fuzzy logic that must be incorporated to do that. You want a common semantic underlying that data. So mapping different coding schemes to a common ontology to be able to generate population level insights around that data while addressing issues of consent and security and pulling all that information together is quite a challenge to then be able to activate it in a multidimensional fashion. And I would kind of tease out of that three elements really of this activation. If you have the data, what are insights you can drive off of that data for a given patient? What's the next best action to take on that patient? What is their potential profile, around risk or social determinants, for example? What is the revenue opportunity? What's their psychographic profile? Can we infer that? What's the best way to engage or communicate with them? Those are kind of the insights you can then drive off of that data using data science, and other technologies, machine learning, for example, to really look at the insights part. And then the second is workflow. How do you drive those insights and that data into the workflow of the care provider, the care team, the physician, contact management operators? How do you sort of activate it for workflow? And then finally, for dashboards, executive perspective, how do we measure the efficacy of our loyalty efforts and engagement efforts, campaign management? So I think the activation, I look at, insights, workflow, and dashboards, and then ultimately doing that at scale to sort of continue the readout of the slide here a little bit. So that's the first take on that. Any other thoughts?
Well, wonderful, Chris. I'd love to get Lucas's thought. This is Lucas. You live in this world. You're dealing with clients who are struggling with this. Give us your sense. What happens if you can't get access to the data you need? What are the what are the challenges that you're seeing in terms of data sets that aren't available or accessible, and what is the consequence when you don't have that kind of data?
Yeah, no, it's a great question. One thing that's interesting to me, the the bulk of my career was spent in technology consulting, and we worked across industries, including healthcare, but there are industries, you know, financial, energy, all these different organizations that, as my career evolved, I started in consulting in '99. As my career evolved, I saw these different industries solving these problems in different ways, but we really saw some great innovation. And on the healthcare side, it seems like it's just taking so much longer. And I know there's a number of different reasons for that, but you know, you look at it today, Google and Facebook and these other companies, I so much as think about something, and all of a sudden I'm getting ads pushed there. It's like they know me better than some of my friends that have known me for years. But if you base it on the kind of information you're seeing, yet something that's so important to all of us, which is our health and having access to that data, it seems like it's so much more difficult and it's taking so much longer. And so, you know, again, there's definitely reasons for that, and obviously the privacy of the data and making sure that it's secure. But at the same time, I think a lot of these organizations, you know, in healthcare almost view it as their data, and it's not. It's the patient's data, and that's the way it should be treated. And so, you know, all of these silos that have been created, and you know, keeping people out, and you know, we mentioned a lot of these EMRs and these other systems that have been built over the years. To John's point, a lot of this started as, well, how do we bill? Well, when you have a system that was built for billing, they're not thinking about interoperability. They're just thinking, hey, we need to capture the transactional data and move that, you know, and be able to bill that. Now that we're, you know, really with the focus on value-based care and truly a focus on outcomes, we have to have access to all that data. And some of the things that, you know, we see on our side, specifically for the way we engage with our customers, I mean, or our patients, we really look at it as, you know, kind of that whole person approach, meaning we're not treating a disease, we're not, you know, treating a symptom, we're not just dealing with what prescriptions are on. We need to understand that person, not only from, you know, what chronic conditions they have, what medications are they on, what are their, you know, their social determinants, you know, do they have housing issues or transportation issues or food issues, needing to understand all that. So bringing that together is critical. And when we don't have the ability to do that, it creates blind spots for us, and it can reduce that quality of care, because we need to make sure that we're coordinating across, you know, the primary care providers, the hospitals, the specialists, and then even being able to bring in different caregivers that, you know, that patient may trust and may want as part of their kind of, you know, inner circle to help provide healthcare for them. So, you know, it's part of the reason that I decided to join Upstream is because I feel like we are at the point, especially with, like, you know, the Cures Act that was passed, and really trying to break down these barriers of saying you can't just have silos of data. You must share that with other organizations, because at the end of the day, you know, like I said before, this is the patient's data. It's not a provider. It's not, you know, any organizations. It's the patient's data, and whoever is helping provide care for that patient is truly the one that needs to have access to it.
That's great. That's wonderful. Hopefully you guys can all hear me. I lost battery on my AirPods, but we're going to keep going. So if we go to the next slide, let's hear from our audience again. So as a healthcare system, which part of the healthcare consumer journey is currently most challenging to you all in terms of providing a personalized and seamless experience? And once again, we'll throw up a poll question. We'll give you a few minutes to respond, and then I'd love to get the reaction from our group when we come back on the other end.
Okay. Let's see whether we can throw the results up on the screen here.
Yep, this is good. Hopefully everybody's seeing. So it looks like we've got about 54% have weighed in at the keeping patients for life. Not too far behind is the guiding. So really kind of that operational transitional care management. The fewest amount of respondees in terms of difficulty in finding, which is good.
Anyone else want to comment on this?
I can tell you I'm not terribly surprised. This falls in line, I think, as we go back to more of the traditional healthcare CRM. Healthcare CRM has been around for a long time. I think, as I speak from a health system perspective, that departments have gotten very good at finding consumers. We have a lot of great data resources to be able to tap into, and it goes back to marketing data, Experian data, psychographic, that magazine subscription data that Chris was talking about, right? I think healthcare as a whole, particularly led by marketing departments, has started to do a really good job on the acquisition, the finding. But I can tell you what we're hearing really pound down that door is the keepage. It's that keepage quotient. And I think probably our third theme is going to round home on that. So that's my initial take on responses.
Yeah, I guess to add to that, the guiding consumers. I mean, I can say we've had a firsthand experience with that. With some things we were. I have 3 kids, and our youngest, our son. We had some things going on with him, and trying to navigate the healthcare system was a nightmare. And I've told so many of our providers that it feels like you're just sort of out there on your own, and being able to help guide consumers and patients through that is so important, because feeling like you have that one person you can go to, or that one number you can reach out to and say, I'm not sure where to go next. I truthfully, there are at some points I'm like, I don't know how other people are dealing with this. When you're going from provider to provider and facility to facility, that's again with part of our model, what we're trying to solve, at least on the for the chronic care patients. But I think just across the board, from the time you're born till the time you leave this world, I mean, healthcare is part of your life, and being able to effectively guide people through that journey, I think we have a lot of positive directions we can go with that.
Yeah, I want to build on. Oh, go ahead.
No, please, John, continue.
Oh, I build on what Lucas said and connect it back to our conversation about what is the role of CRM or navigation within healthcare, and connect it to our conversation around what are the settings or sites of care. So we've heard this over and over again. It's navigating the system that is a challenge. So that has to open the idea of what does it mean to keep a patient for life? Well, keeping a patient for life might mean sending them to people in their community that can help them be better. It may be sending them to the right specialist. It may be having a consumer experience that delivers that navigation. And as Lucas said, our upstream model is about building a care team around people so that they get access to the services. And I think those primary care practices that have done this in the past have proven to be more successful. They've had good relationships with not just the specialists, but lots of care experiences within their community. And they know who to call. And their nurses, their care teams are good at that just naturally, even without tools and technology. But that's not scalable, and it's not the status quo. So this notion of navigation shows up lots. We know care coordination and navigation is critical to those most at risk. We know it plays a critical role in oncology care, on oncology navigation. It plays a critical role in cardiology and cardiology patients. How does that become a culture? And how do we use this process of data exchange, interoperability, and modern technology to actually shift that thinking? And I think that's an important challenge for the industry. And I think that poll results sort of lead to some of that, and appreciate the comments on it.
I think that's a perfect segue into our next section. Let's go ahead and cover this area, and then want to leave a few minutes for our audience's questions for us to be able to tackle some of those. So in terms of what, John, you and Lucas both sort of alluded to this, and would love to get any additional thoughts as we go through this material, but also get Rachel and Neela to weigh in as well. But the building that one-to-one care journey, healthcare journey, to sort of go through the sequence of finding those individuals who can benefit from the healthcare services, and then guiding them and especially in the complex care areas, and then making sure that we give them a reason to stay close to that system for their care, I think is incredibly important. And there's different strategies on how one might go about doing that. But if we look at the way that we're leveraging data, and again, you sort of have all alluded to this a bit, are there any other thoughts that you have around the topic of, what are the strategies to help find and then help from a navigation point of view, and then help from a loyalty point of view, or keeping those individuals that you may want to add on? But I'd love to get some thoughts from, some quick thoughts from you guys, and then maybe turn it over to Rachel and Neela to give some thoughts in terms of how they broadly see this from their lens.
Yeah.
Maybe Lucas. Yeah.
Yeah, no, absolutely. Would love to kind of provide, I guess, from our point of view. And again, our kind of patient demographic that we're focused on, are those that are, older with chronic care or chronic conditions. So from a finding perspective in that particular patient demographic, what we're focused on is how do we identify those patients that need our help the most? As John mentioned, we build care teams around these patients so that they have that one point of contact and they can build those long-term relationships. So, some of the things that we're doing right now are actually building the risk models to identify patients that maybe aren't eligible for the program yet, but could be very soon in the future, and the ones that are eligible for the program, are we reaching out to them in a timely manner? So, when I think of finding patients and finding, the ones that we really need to connect to, that goes back to using data and making data-driven decisions, not just, well, here I happen to, this patient happened to come through our door today, so let's go ahead and talk to them and see if they want to join. It's being more proactive in reaching out to that. And I think, to some degrees, you can kind of take that sort of that CRM approach, that traditional CRM approach of, hey, how do we go out and market to, consumers in different industries? In this case, we're really trying to, as our name implies, we're trying to get upstream from when the real problems occur. We don't want to treat the diseases after the fact and say, well, we're sorry you ended up in the hospital for 2 weeks. We want to prevent them from going to the hospital in the first place. So that's, for us, that's what's so important about the finding those patients and getting them on the teams, as quickly as we can. Once they're on the team, again, and I know we talked about this on the previous topic, but guiding them through that journey, because when we engage with patients, we're looking at that as a long-term relationship. We have our care teams and the folks that are working with these patients. They really get to understand who that patient is, what drives them, what are they looking forward to, what are they most fearful of, where are they having problems. And there's situations where, because of the patients that we deal with, they've gone to all these specialists, all these different doctors. They may be on 20 different medications. There are situations where we've taken them from 20 down to 6, and they're healthier than they were before because they didn't have anyone guiding them through this process. And they were listening to their doctors. They were saying, hey, if I need that medication for that, for that condition, I'm just going to take it. But we actually have team members that are looking at their overall situation and saying, well, what's best for you? What's most important to you right now? I understand you have these different, conditions and diseases that we're dealing with, but let's focus on what's going to drive you. And, you talk about adherence and things like that. Well, that's what we're trying to get to ultimately, but it's to drive the outcomes of better care for that patient, which I believe dovetails right into the last one. If you are truly showing that you care about a patient and you're focused on their outcomes, and it's not just a transaction. I mean, we didn't even get into the whole, fee for service to value-based care and that transition. But I mean, when people feel like they're being, treated as a human being, and you genuinely care about their health and happiness, and you're not just coming in saying, well, you said you have this, this, and this, I checked the box, please, please move on. That's what's going to keep them. That's, from a keeping that customer or keeping that patient there, keeping them, engaged, so that they feel like there's value in what you're providing to them. I think those, for us at a high level anyway, with the model that we've implemented, that's really kind of how I see the progression through those different areas.
Yeah.
Very, very helpful.
And a comment that I wanted to make, Lucas, I think you laid out very well how the data needs are different for the find, guide, and keep sections, right? So for the find piece, you're more focused on risk models. And for the guide and keep, though, you really need more insight into the specific clinical data. And I think that is part of also the reason why we find in the poll that there is a gap between the pain points of find and guide and keep, because the latter two require us to be looking at, the clinical sources of data, marrying them with everything that we know about the consumer world. And I think that bridge has not yet been successfully done at a large scale. And that's the piece that we need to really solve.
Yep, I would
Rachel,
agree.
thoughts?
Yeah, and I just advance intentionally. We're getting to the end and we do have some good audience questions, but this is really the universe as we now see it, right? This is what all is required to go in on a visual to the healthcare one-to-one journey. So for us, these are all of the touch points that are really going to connect the find to the guide and to the keep. From my perspective, I think there are a smattering of health systems that are doing one, in some cases, two of these things very, very well. I find that there's very few that have been able to connect the dots, as Lucas was describing so eloquently, across all three. And that's what humanizes the experience. That's what changes the game for us here in healthcare and for us in healthcare in the industry, but for us as patients, right? At some point, we've all been patients. We want to be treated like we are in other retail verticals. We want that Amazon experience, but we need it even more so in healthcare. So I just like this visual, and I think it would be good for us to actually leave this up for a few minutes so folks can digest, and perhaps it prompts a few more questions.
That's awesome, Rachel. Why don't we go ahead and see if the audience has questions? I'm going to need a little bit of help, maybe from you, Rachel, in terms of what questions have come in. And then maybe you can read the question, and perhaps I can take a stab at directing it to one of our panelists, and then we'll wrap up. And I hope you guys can all stay for a few extra minutes. I know we started a few minutes late, so we'll extend this by just a few minutes here.
Perfect. Thank you. Yeah, we've gotten some good ones in. So I'm going to start in the order in which they came in. So it's probably going to take us kind of back to our earlier themes. Keep in mind, again, kind of consumerism and digital transformation at the helm of all of this. So the first audience question is, how does the Affordable Care Act impact any of these equations around digital transformation, noting that it does bring in a different payer group?
Well, I got to direct this to Lucas or John first. One of you want to take a stab at this?
Oh, I'm happy to kick off, and I think a lot of things in the Affordable Care Act that then led to that some preceded in the High Tech Act, and as Lucas said, the Cures Act, which is newer, about interoperability, are pushing that notion that healthcare is happening in lots of settings, and unless the data is being shared, it isn't going to be effective for sort of where we ended on driving a patient journey through a set of different care settings. So I think not the Affordable Care Act alone, but all of the regulatory guidance that I think rightfully so, Health and Human Services and its various arms and legislative authority and regulatory authority are pushing towards this, but there's still a lot of work to be done, as we've talked about here. So I think it's a good start, but probably insufficient to solve many of the data questions that we're being challenged with.
Gave us some rules of the road in terms of how we can pull that data together, plus promoted just the notion of doing that digitization around it. To your point, John, now with the Cures Act too, you really bring the patient individually into it to create that truly patient-centric opportunity to pull that data out, because as Lucas said, it is indeed the patient's data ultimately. So that's a great reinforcing mechanism, I think, from a legislative perspective to ultimately achieve that patient-centered care, and how folks like us can then take that, leverage that to create the unique experiences that we see here, on this screen.
So if we had a lot more time, I would probably ask you guys if additional legislation is needed to further accelerate, but I'm not going to ask you that question. I'm sorry, Rachel, go ahead.
No, I think this relates just on Chris's note too, to the next question that we had, and it goes a bit more into the technical. So Chris, if I'm so bold, I'll probably direct this one back to you too. But the question is, are there any companies that are working on an interoperability warehouse where the data can be sent, it can be reformatted to be readable as data by different EHRs rather than what a lot of folks are accustomed to, right? Simple PDFs and image files. The comment to follow this question, and I think we all are nodding our head in agreement, is that current data warehouses are so limited in how they handle data exchange. Chris, knowing you're an architect, I think you'd be really well suited to speak to this.
Thanks, Rachel. Yeah, no, I think that there are companies doing that. I can think of one in particular, but no, in particular, the way that we approach that problem set is indeed pulling the data together, getting the core semantics of it really understood in a common data model in the cloud. Here, one second. And then making it interoperable back to the point of care, driving insights into the point of care. Part of that is, leveraging these standards to be able to bring discrete data, in across the gamuts of where the providers are actually leveraging and caring for their patient. But the other technology approach that we apply is really an overlay to get a little bit deeper into the technology piece, where we've got sometimes there's so many, there's so much fragmentation in the EMR space, particularly the ambulatory side. There's not common EMR out there. There's many that have been widely adopted, and there's specific EMR approaches you can take to bring in insights. We've developed technology that enables this overlay that can work with any EMR, can read the screen, who's the current patient, bring insights, bring that data in without having to solve sort of how to interoperate with the data model directly of that EMR, and be able to work across really any kind of system as an example of maybe to be able to provide for the care provider next best action, different insights, risk profile for that patient, gaps in care directly into that point of care.
I would also encourage our listeners to perhaps look into the Trusted Exchange Framework and Common Agreements, the TEFCA rules that were recently finalized by Congress. I think it gives an interesting way of looking at how folks can bring data together and make it available to sort of unify what has been a fragmented HIE or health information exchange type of framework. So perhaps it's a different webinar on a different day, but there is some work that's being done, and folks like Innovacer, I'm sure upstream, we're going to be paying very close attention to how that benefits our constituents through that journey of getting the right data to the right person at the right time. So Rachel, any other questions in the queue?
Yeah, we've got two more, and then two more questions, and then we'll wrap up and give folks their day back. So the first one is, it's a big one, and maybe one we should have set the stage with today, but it's really, how are you defining healthcare, right? And the comments after that are, plans deliver service and community providers deliver services that have real-time data entry. I think any of us could answer this question. I know for me, I represent healthcare from the hospital and health system sector, but that's just one sector, right? That is providers delivering services. So would love to hear from the rest of you about kind of how you see the healthcare lens, and perhaps upstream, the guys from upstream, you would be well suited to be able to answer from your lens.
And Rachel, I'm going to take the liberty as a moderator to add a little bit of nuance to that question. If you could also comment on not only that question, but also what does the ACO reach mean in terms of how the government may be interpreting healthcare and who should be providing it, and some of the requests for information from the White House in terms of community health and things of that sort. So we'd love to get John and Lucas, your perspectives on that. So I think it's a great question.
Yeah, no, I like that. And I think it is a great question. And I think thread throughout our conversation, we talked about data further into the community. So I think when I see healthcare, I want to attach in the language there, healthcare services, the delivery of those services to improve people's health. And if you ascribe to a social determinants of health thinking or mindset, you'll also probably think that those healthcare services probably broadly touch 15 to 20% of the health and well-being, and I'll broadly call it a community. I like that term in this area. So we've got to be thinking more broadly. So in my mind, I think about the health and well-being of a community, its ability to thrive, its ability to have a workforce that can be employed and at work and productive, its ability to have schools and educations that is successful, its ability to take care of its seniors and provide them the services. And I think about all of the services or the experiences that go into that will move that more towards better health outcomes, less use of traditional health services. Those aren't going away. We need them. And as we touched on, when we have things like EDs that have to serve the most critical trauma cases and are meeting the needs of parents with flus and colds because there is no setting of care that's convenient for them, it puts a strain on the system. So I think about that broadly. I think to follow up, I believe that the government, CMS specifically with ACO REACH, the initiatives around health equity, these are all pushes to understand that healthcare services, what I think traditionally we've thought about is healthcare, are critical. We within the United States are fortunate to deliver some of the best ones in the world, and people seek those out. And at the same time, we struggle to have the health and well-being of our communities be as strong as it can be. And I think these are opportunities, both the sort of data-fueled ones we've talked about, but shifts in payment models, shifts in responsibility, shifts in the role of healthcare teams and providers to think about the health and well-being of communities as our base. And I say that knowing that it's not easy to measure that. We don't have a lot of good standards, but that becomes our challenge. And I think how we should be thinking about it.
So Rachel, maybe we have time for a very, one more question, maybe if it's a quick question, and then we'll wrap up.
Yeah, perfect. And I'm going to, while I'm asking the question, go to the last slide. So if those of you who did not get a chance to ask, there's an email on here. Feel free to reach out and we'll be happy to get back to you. But last question. So do you see one of the potential solutions to this as an approved relationship between patient and the industry and company? Amazon gives thousands of dollars in services for being able to leverage our data as the example.
So I'll add my 2 cents on this. This could be its own topic for a whole hour, I think. But really, yeah. I think some of the things that we're looking at there, and this goes back to the whole idea of the, that patient-owned medical record. And I think we're seeing some advances in areas like blockchain, where that's going to become a reality, where we actually do have the technology to leverage that and have it shared across the different organizations, but still be owned and controlled by the patient. So. Again, that's a whole path of discussion we can go down, but I mean, I think that's kind of where we're moving, and it's the difference. I think is going to be we have to make sure where right now, I feel there's a general sense that people are losing control of their own data, and really they're giving it away freely in many cases. But and when we talk about things like Web 3.0 and moving to blockchain and taking the ownership of that back, I think that's a critical path that we need to be going down, especially from a healthcare perspective. So that's about this. That's the summary of that, but would love to get into that topic in more detail in another session.
Yeah, I think that would be a great roundtable for us to participate in, perhaps maybe together with some other industry colleagues. Well, this has been wonderful. I really appreciate the panelists' comments. Appreciate the questions from the audience. Thank you for attending. I know that we'll have the recording available. And again, as Rachel mentioned, feel free to message us or email us and let us know if there's anything else on your mind, and we'll be happy to get back to you with our thoughts. Well, thank you for joining us. Bye-bye.
Thank you so much. Bye.
Thank you.